Okay, well, good morning, everybody, and welcome to the November meeting of the West Suffolk Clinical Commissioning Group, a governing body. Joe, do we have any apologies?
I've got apologies from David Taylor, Victoria Wilson, Godfrey Reynolds and Steve Chicken.
Thank you. Are there any declarations of interest?
No, not from me.
Nobody else either. Hospitality gifts? No, thank you. So could we look please at the minutes of the last governing body, which took place 2 months ago in this format? Are there any challenges for accuracy?
No.
Thank you. So may we approve those as a correct record? Thank you. Thank you. Yeah. Are there any matters arising not covered elsewhere in the discussion, not likely to be covered elsewhere in the discussions today? Okay, thank you. The action log.
Okay, so 062 was around procurement, and the request was, following the procurement update, that the executive would have a separate discussion around pathology and mental health for levels under you.
Thank you.
I think if Paul's not online, I think that we have spoken about pathology, and I think we've got a mental health update pending. So maybe we should leave that on.
Apologies, sorry, there was some noise I couldn't quite hear. Yeah, in terms of the pathology, we took that to the exec. In terms of the next direction of travel, took a paper there which was agreed in principle. So we did provide an update at that point.
So if we still got to have a mental health update,
I believe Richard provided a verbal update at that meeting too.
So the outcome, if you recall, we agreed to extend the timeframes for the mental health crisis element of the model till January, so it'll be coming to the January governing body, but we'll be giving an update more broadly through the main performance pack as well.
Okay, brilliant. 064 was the GABAF, and this was centred around the conversations for Stanton surgery extension. And these have continued, and there's another one tomorrow. Actually, it's not necessarily been resolved, but these are ongoing. So we can happy to bring in.
I thought it had Kate in terms of Stanton planning permission.
The planning permission has, but there is a broader conversation, I think, about the kind of ambition surrounding that. So absolutely, the planning permission has been. So it might be that Christopher, we bring back an update if there is one linked to the future systems conversations that are also running as part of that conversation.
I think we probably close that, can't we? Because the planning permission which that relates to is sorted, and any other issues we can bring as new issues if they arise and come to anything.
Okay, brilliant. Yeah. And the last one was around 111. Richard, do you have an update?
The update's on the pack, so I linked Councillor Marks with Sandy, and they've taken that forward.
Fabulous, so that can come off.
Okay.
That's it, Christopher.
Thank you. That's it. Thank you very much indeed. Ed, a general update.
Thank you, Christopher. So to start with some achievements, so Julie Irving, who is part of our IT team, has been named Information Sharing Champion of the Year for the NHS, which is a huge achievement for Julie and her team and the CCGs. And this is around her work on My Care Record, which allows health and care professionals to have access to records and therefore improve patient safety and provide improved care. So very well done to Julie. Secondly, the partnership in Suffolk working on SEND have received a national award for their 16 plus transition guide. So this is for young people transitioning into adulthood, which is one of the key risks around SEND, is that people fall between services. So it's very encouraging that we've had this national recognition. And I know that SEND is on the agenda later, but we are seeing metrics-wise some clear improvements, such as statutory assessments around SEND, currently 96% for November, compared to 42% this time a year ago. So we're seeing some really great work from all partners involved with SEND. The key thing now is the impact for the individuals and their families, and seeing that positive impact come through from the work. Thirdly, there's some really encouraging news about the mental health crisis phone line, which we've discussed previously at this board, and the volume of work it's got through in the last 7 months. So there's been 25,000 callers and some very good feedback about the service. So that was excellent news, very important in the current context. We'll talk about COVID on the agenda, but obviously COVID vaccination is a big priority for everyone, and an absolutely definitive moment in terms of the response to the pandemic. And there are three kind of areas of work. One, NHS trusts preparing to vaccinate their staff from December onwards. The agreement of mass vaccination sites, which we're currently in the process of pinning down, and then also the work that will be done through our primary care networks as well. So a big, complicated programme, but some excellent work being done by many colleagues. So thank you there. And also in terms of COVID testing, there are lateral flow tests being delivered to trusts up and down the country, which is point of care testing type tests for COVID, which is key to keeping our people safe and operations going. The next thing I want to just reference is the comprehensive spending review, which will be announced today, and there's £3 billion announced nationally for the NHS to tackle waiting lists, improve mental health services, and put more capacity in terms of diagnostic services. So that's very welcome news. We'll be talking about EU exit on the agenda, but I think this is the last governing body before we exit the European Union in the end of December. So we're very live to that issue, and there's a lot of work going on in terms of contingency planning and business continuity planning to prepare for that. The final two things I want to touch upon is one, the government will be preparing an NHS bill in probably starting the process in January, which is likely to have information about integrated care systems and how they're potentially given a legislative basis. We're expecting some information prior to Christmas to give us a sense of what that bill may be constructed around, and we'll talk about that once we have some information to discuss. And then finally, just a very well done to all our member practices and primary care teams. So the vaccination rate for MMR, measles, mumps and rubella, is very high in West Suffolk, the highest in the region, amongst the highest nationally. We hit the national standard for the last quarter. So well done to everyone involved in this this achievement on the call. It's brilliant news for our population. So a great point to end on, Chair. Thank you.
Thank you very much indeed. Does anybody have any questions for Ed? Thank you. Thank you very much, Ed. Okay, now on to the next section, strategy and service development. And I'd like to welcome Barbara Gale, who's with us, or was a minute ago, to present the patient story and the St Nicholas Hospice for Deaf Literacy plan.
Thank you very much, Christopher. I have a few slides that I'd like to share, which I'll try and do now.
While Barbara's sharing, can I just take the opportunity, because we've got her here, just to publicly say a thank you to the hospice for the role they've played in the Alliance full stop, but definitely during the recent crisis in terms of leading the Alliance team and broader than that around on our end of life model and being possibly in keeping with their strategy throughout in terms of moving stuff into the community, but just providing an exceptional response in a very difficult time, and Barbara for her leadership of that as well, which has been fantastic and much appreciated.
Thank you, Kate. And in fact, I've just let the hospital know that we've released some space so they can do some of their vaccination programme here at the hospice for staff.
Fabulous.
So I think that's great joint working. And I think that's very much what I want to talk about today, is about we need to take a system approach. And I think I'm so pleased that we have the ambition in the West that we want to give people the best start in life, but we want to give people the best end in life. And I've been working at St Nicholas Hospice Care now for 15 years. And my opinion of how we approach this has changed. I think we have such innovation that we need to do. We need to really think differently about how we're going to support people around death and grief. And we have amazing resources around public health approach and asset-based community approaches that we really need to grasp if we're going to do this. So I'm going to talk you through what we're doing at the hospice, but also how we need to approach this as a system. So St Nicholas Hospice Care over the last years has realised that we need to work differently. We need to influence more people's experiences. We need to not just be seen as a building where people die, but we need to be there for everybody who's facing death and grief. Not necessarily we do that ourselves, but we're influencing their experiences. And as a charity going through very difficult times, we need to do this in a way that's sustainable. We can't carry on with deficit budgets. And we've recently, sadly, had to put a restructure in place where sadly members of staff need to be made redundant. We've done that through a collective consultation process, which is now just coming to an end. But we're doing this in a way to deliver a model of care and support to this community that's sustainable. And that is a different model, which I'll talk through. It's also, we're passionate about putting dying back into the heart of the community. Death and grief are not illnesses. They are normal processes we go through. What we did a few years ago, we went out and talked to people facing death and grief and their family members. Not just people known to the hospice, because if we'd gone and said to people, what do you think of hospice care? Some would have said, oh, you're marvellous, just do more. Some would have gone, I have no idea what you do. And there would be the people in the middle. So we asked people to talk about their experiences. And these are some of the quotes that people told us. The importance of dignity, how you're treated, how you're respected as a person, as a mother, as a son. People who've been through several experiences said on the second time they'd be less frightened of coping with their own death, and they'd know what to do if they went through the experience again, because the first time they didn't know what to do. They didn't know who to call. They didn't know what death was going to look like. And the people who had a good support network around them, and I don't mean nurses and doctors, I mean neighbours, family, friends, seemed to have a better experience. We also heard from people who struggled for support out of hours. They had to wait hours for pain relief. But some of those families said that if you told me how to give that drug, I would have given it. And I'm really pleased during the COVID crisis, we agreed a policy for the region that ensured that family members could be trained to give end-of-life drugs subcutaneously. And that's a real success story for us all. So we developed a new model that changed from just about providing services, but wanted to shift our energy in equipping everyone to live with dying, death and grief. So that's our families, our communities, us, that's you and me, and that we all need to be better informed. You know, my daughter, I often talk about this story, and Ed and Kate have heard it before, but my daughter had a baby recently and she was really well prepared, as were all of us, about what was going to happen. And I went through all that again. We're not doing the same about death. People are approaching that experience of death not knowing what's going to happen. And that's where death literacy comes in. And that's what I'm going to talk about as well. So we have to take a systems approach, and the community has to be part of that system. Yes, we do need to provide good health and social care, medical care and specialist care. And we do need to organise ourselves better and coordinate. I'm very much part of a system at the moment, that a working group that is looking at how we improve patient electronic centred records that can be shared, visible and accessible by patients and families as well, and be kept up to date, so that we no longer have these systems where people have a do not resuscitate order in hospital but not in the community, and you can't see each other. I know that's just a one thing, and it's advanced care planning is more than resuscitation, but we've got to get our systems better. We have to work more collaboratively together. And I think during COVID, I saw my team and the community team take a much more integrated, collaborative approach in understanding who needed support that day and where that support was going to come from. And we need to build on that. But we have to innovate. We have to think differently. We won't get different results by doing the same thing over again. So one of the things we learned when we talked to people about how they lived with dying is they might see lots of professionals. I mean, families sometimes talk about 40 or 50 people stepping over their doorstep. I know that might be less at the moment, but actually most of their time might actually be spent alone or with family, friends and their community. But yet what we often do is we're concentrating on the professional resources and times. We're not concentrating on equipping those family, friends and community, how they support each other. And I think in Suffolk, we have such an opportunity now, because we've seen communities rally. In my own village, I've got a Facebook group I'm part of, where if somebody says, you know, Mrs. Smith needs a Addenbrooke's appointment, but she's got no transport, could somebody take her? You see messages coming backwards and forwards. What I want to see is somebody saying, is my mum's coming home to die, who could give me a hand? That's what I want to see in the future, that communities feel confident in being able to support each other. So one of the terms that's been developed through research in Australia is a term called death literacy. And I think we often have thought about literacy as about speaking and talking, but it's not. Their research showed that it's about knowledge, understanding, and action. So I think one of the things we perhaps haven't done as well in this country is that every year we have this Dying Matters Week, where we talk about dying and talk about planning. We rarely talk about action. We rarely inspire people to do something that week, to speak to somebody, to help with equipment. And I think we have to move from talking into action, but people need to be prepared. So this death literacy is built on a scale where we know that literacy is built on knowledge, practical skills, community knowledge, and experiential knowledge. And actually, if you have that knowledge, you then feel more inspired to act. So Australia also developed something called a death literacy index, that was a tool that could be used to measure death literacy in the population. A survey with 152 items that talked about experience, community, questions about death and grief, and questions about action. This was an index that actually we were part of that research, and we tested it in Mildenhall community after a piece of work that we did with that community to support them in really using an asset-based community approach to improve the support they could give to each other around death and grief. So I suppose I'd quite like you all to have a look at this page and just look at the questions and think about how death literate we all are. You know, think about, some of us are probably better in some areas than others, particularly about navigating the healthcare system, I would hope, those sitting on this panel, on this meeting, but how many of us know about accessing equipment, accessing local support in the community, knowing who they could contact, knowing who could help them, knowing what documents you need, because you do need the experience is better if you've got your lasting power of attorney, if you've made your will, you've done your advanced care plan, you've spoken to your family, you've talked about organ donation. You know, things work better. There's a lot of research that often talks about people who have done their advanced care plan, and North East Essex uses My Care Choices. So it's not the document that makes the difference. It's the conversation that you have with your professionals who are involved with you and with your family and friends. So some of the results that we saw when we measured death literacy in Mildenhall, we also did a similar survey in Sudbury recently. And this was circulated to people we were in contact and people we knew, whereas the Australian population survey was actually done with a representative sample of the Australian population, which is why the scores are slightly different. But this is a way of measuring how death literate people are in that community. And one of the really interesting results for me is where people learn their experience. And most people learn their experiences through personal experience and through their group. And whilst the scores are slightly different, you can see that there are general similarities of where people learn their knowledge, and you can see how actually fiction, television, books, and I would say probably social media, people learn things, but they may not be learning the right things. So I think that's something we can really build on. So the Death Literacy Index is something we've tested in West Suffolk, is something I would really like to see us use more. But I think we will need to use it as part of the interventions that we need to do as a community, which the hospice is really wants to be integral in supporting about how we improve all our death literacy so we can support people as they face death and grief. And I would really encourage us always to be using the words death and grief rather than end of life, passed away, really using that clarity. We are all going to die. We all need to prepare for it. But I think there is a lot of work we can do together to make sure that we're all better prepared and informed. So the Death Literacy Index can be used in research, evaluation, but it can also be used in a more playful way to start conversations and see how conversations are working in a way that I've put those questions up for you today for you to think about. So one of the areas that I think we will be wanting to use it is we've been doing a lot of work in schools called Life's Questions. And I don't know if any of you heard of it. It was developed from something called Grave Talk, which was started many years ago by the Church of England, which was getting people together in small groups with tea and cake. This is all going to be much easier when we've all vaccinated. And talking about wills, funerals, favourite places, all sorts of things, just to encourage conversations. And one of our team, Lisa, who's in the middle there, thought, well, that's great. But one of her children was hearing her talk about it and said, well, why don't we do that in school, Mum? So she went, oh, all right then. So she tested it out in her on her kitchen table with sort of any child that she could reach through her neighbours, and they came and tested it out together. And it worked quite well. And she used it. So it's a card system where you turn cards over and there's a question on it and you then talk about it in a group. And she's taken it into schools. And they got put forward. I could get quite emotional talking about this. Put forward to for the Nursing Times Award, and they won. And really amazing work. I mean, children are talking about death and grief. Their teachers are seeing how that children are able to do that. And it's a scheme that actually the person who gave the award wants to take it into London schools. We're now preparing a toolkit so that schools can use it. But to show that it's really effective in development, the Death Literacy Index is something that we can use in those populations of schools and use to measure how this work is actually improving people's death literacy. So I think there are lots of schemes that not just the hospice, but the communities are involved in, that we can really support and develop. to make sure that we're all better prepared. Because I think we all need to know what to do when somebody's dying, and we all need to feel better supported by our friends, our colleagues, our workplaces. But we also all need to be better at asking and accepting help. Thank you. I'm happy to take questions.
Thank you very much, Barbara. That was not only most interesting, but a salutary reminder to those of us who spend the greater part of our professional lives helping, we think, people to postpone the date of what you've reminded us as inevitable. And in the case of the medical members, only really touching death in the few days around the time when it happens sometimes. Questions? Lisa?
I think Kate was first, but
no, you go.
So I wanted to echo Kate's comments at the beginning about Barbara's leadership and St Nick's leadership, actually not just in West Suffolk but across the whole of Suffolk and North East Essex, particularly on this agenda. They bring a whole new type of conversation and discussion to all our partners across Suffolk and North East Essex. And I was really struck, Barbara, by your slide that showed the breakdown of contact around professionals being 5% and family, friends and community being 95%. I haven't seen that before. That was quite striking, because you're right, we do very much concentrate on the professionals model and how do we support the culture of professionals being able to have this conversation better rather than the community. And I know that's kind of fundamental to your strategy and how you take it forward. So if there's anything further that we can do to help or anything practical that you need, I'm really supportive of it, and let us know. Thank you.
For me, I think we need to all sort of embrace this culture change, that death is not an illness. People who are dying have illnesses that need treatment, and they need that right medical support. But death is a normal social experience. And I just think our energies that we should, every time we meet somebody, we shouldn't be just saying, oh, if you have a problem, ring us. We should be saying, if you have a problem, this is what you need to do. Who have you got around to support you? Have you got neighbours? Have you got somebody who doesn't sleep at night either you could ring in the middle of the night? We need to encourage people. And I think doctors have a really strong role to play in encouraging people to be able to use that support. We know with social prescribing that if the doctor says it's all right to use a group and use that social network to improve your health and well-being, people are much more likely to accept it. And if we say, well, there, if you get stuck, but actually use your family and friends and network. So I think it's a cultural shift we have to take.
Thank you. Kate?
That kind of links to my point, really. And I think I always find it fascinating when I listen to Barbara talk and hear about the work of the hospice, just what an impact it does have, because you realise how very seldom you talk that frankly. It almost makes you wince when it shouldn't make you wince, because this is the cultural piece that we do need to change. And I think we, as a system, need to acknowledge how brave I think our hospice team is being in making this as a decision, because it's a much safer space to sit in the beds section, carefully crafting the perfect offer of support in that sort of safer environment. To take that out and disperse it and put it in the hands of our communities is a huge shift from a commissioning point of view, from a mindset point of view, even from a professional point of view, in terms of how our end-of-life professionals view their role and the walls and ceilings around their role. So I think that we're very lucky to have it, and I think that level of ambition in our system, that level of leadership, but also we need to acknowledge our own role. We're going to have to get behind this properly, and that goes into how we commission our community services, how we the conversations that we have with our acute providers, how we are developing our localities, all of it knits together very well. And I love the school example. And I feel I'm always a crack record being married to a teacher. But when I hear about the children's experience where they've had a death within their family and the complete close down very often of them as a mini human being, it is heartbreaking. So the stronger we can get the messaging of what the support is and just normalise the talking about it, I think that in itself is a significant win. And also the point you made, Barbara, within your slides about the support being culturally appropriate. I think that links to obviously the BAME agenda, but more broadly, if we're looking at our communities and how we support our communities, we will learn so much from these conversations about what's needed. And again, that needs to feed back up into our approach to developing our community assets and our approach to our sort of commissioning model as well. Thank you, Barbara.
Thank you. Zora.
Actually, my comments are going to be very similar to Kate's. So Barbara, everyone at the hospice is doing an excellent job, and I think death literacy is definitely so important. People come home with their dying relatives and often phone us as GPs because the relatives maybe not drinking and they want some build-up drinks, but haven't had that conversation about what are we doing trying to force drinks down them, and that they just haven't had that word death even talked about sometimes. And actually, I had a difficult conversation with a gentleman that I'd never met before. I'd never met him or his wife, and said it. And I said, she might die if you don't give her anything to drink, but that's okay. And I felt like, it felt awful. But then I phoned him a couple of days later, and he said, "You know what? I'm so glad that you talked about it. It can go in different ways, can't it?"
So I'd really recommend for anybody who's not seen it, and even to give to patients and families, there is an amazing video by Catherine Mannix on the dying process done with the BBC, where she explains what dying looks like and sounds like. And it gives new doctors, experienced doctors, people themselves, a language to use about what dying looks like and how to explain it. And there are all this information out there. We've got to be more transparent with people earlier, not just at the end.
Yes.
Thank you.
And I was just, and also the culture approach stuff, that was nice that was on a slide as well, because obviously that's something that we need to recognise too. But thank you for all your work, and the nurses are excellent for advice. We always thought the hospice was about cancer, but we're using their support for people dying with dementia and lots of other things. And I think that's a big difference over the last sort of 15-20 years, because hospices were about cancer primarily, and now, like you say, it's dying in general. It's support for everybody, which we just need and really value. And I worry about you talking about the financial constraints, and we need those conversations open so that you are supported and can support us as well. Thank you.
Thank you. Linda.
Thank you, and thank you, Barbara, for that excellent presentation and the work that's happening. And you talk about a cultural change in our society, and that often starts at grassroots, doesn't it? In sort of local village halls, in WIs, in even mother and baby groups and all sorts, just talking about how we support people. And often we're quite a reticent society, and not knowing what to say and whether we put a foot in it, or whether we can ask these questions, or whether indeed we can be that blunt and use such words. And I think, you know, we all need a bit of guidance and support in that. And I'm sure members of the community engagement group from at the CCG and many others would be happy to be supported to be able to go out into the local communities and start having those conversations, or be taught how to have those conversations. So you get that cascade going through the community. So I would love to invite you or somebody from your team to come and talk to us and begin it in a very small way.
Be happy to.
Thank you, Barbara. Thank you.
Thank you. Ed.
Thank you. So I obviously agree with Lisa and Kate's comments. You're a very special leader, Barbara. But that wasn't my point, as important as it is. So the question of the schools, I'm just thinking about this from an alliance perspective and how we could potentially build this into the curriculum of the schools in West Suffolk or across Suffolk or across the ICS. So I'll just have a chat to Kate about that, because obviously we've got Nicholas is involved in the alliance now, isn't he, and being quite enthusiastically involved. So I wonder whether there's a conversation with West Suffolk College about whether you may have already been doing this, Barbara.
So we've been very much working with Beth Mosley and her team and being aware. But I think there's something about, I think we have got to a point now where we've tested it and run it so much that it could become much more mainstream.
Yeah, it's about coverage, I think, now, isn't it? And looking at the model,
especially if we're doing it across the world, and we've done it for teachers in Australia. It feels that we should be doing it for teachers everywhere here, really.
I think that'd be really exciting to mainstream it, and I'm very happy if you wanted to present this at the ICS board. We could have a bit of conversation.
I am coming to present at the ICS board,
okay,
and I was going to sneak that bit in as well, but thank you, I'll do that too.
Good.
Thank you. Andy.
Yeah, no, actually, the last Ed's comment there, I just wanted to raise about the operationalization of your vision, really, Barbara. But and it's such a fantastic vision, and what we've just discussed about taking to the board, and we're getting to the. You're getting to the stage, or you've already been at the stage where to make this mainstream and operationalize it, and I'm sure you're thinking about that all the time. And but that is, you know, just something we can help with and want to, and taking it to the board is very a good idea. I just wanted to ask, in terms of consistency with the other hospices and the other end-of-life services, I suppose, where are they in this journey?
That's a very good question. I think we're all very committed to improving quality support for people at end of life. And I think the compassionate community side of that development is a wish for other hospices. I think we're much further ahead in the West in engaging our communities. I mean, as part of our new model, we're going to be employing community connectors to really work with communities about end of life. And we're looking at in a system where our nurses are going to be, rather than just run by the hospice, but actually very much integrated along primary care teams. That is a slightly different approach to other hospices, but our ambitions and our wishes are very much the same. I think we see ourselves in making sure that everybody is so well equipped that we're not needed quite as much. I don't think that's going to happen for a little while, but rather than to actually build our business up. And I think that's probably the difference.
Okay, thank you.
Thank you, and thank you very much. Any further questions on that section? Well, Barbara, thank you very much. We are very grateful, and I echo everybody's thanks, certainly for the work you do in the end of life group, which I'm part of, and that is very appreciated. And as you will now get your wish, you may leave should you wish to.
Thank you.
Thank you. Right, so we now go on to the West Suffolk Alliance update. Kate, if you would, please.
I will. Can I just apologise? I can't split my screen, so I have to have it up in front of me. I'm going to take, given where we are with time, I'm going to take some of it as read, but just to walk you through some of the highlights from the work that we've been doing as an alliance. And I think that Barbara's kicked us off with that, really, in terms of that being a fantastic representation of how we are developing a system approach to end of life, which was given a fast track as part of COVID, but we've managed to do that in keeping with what the original strategy was. So the pieces I wanted to pick out of the paper were around, firstly, winter pressures. And I think there's been lots of discussion about the multiple layers of complexity that we as a system, as a population, as well as kind of from a provider point of view, we're going to have to juggle during winter. And winter isn't just about Christmas, it is stretches now, it seems, until Easter. But so in terms of the planning and the prep for this, we've had a slightly different approach, building on the learning from COVID. And we have had a weekly meeting in place now for, I think, about 6 weeks, possibly 5 or 6 weeks, chaired by our Director of Adult Services for Essex County Council, which has had all of us, representation from all of our system partners, I think, to talk through, building on the winter plan, the ICS winter plan, talk through the bits that need a system approach to solving the problem, whether that's looking at how we mobilise staff, utilise beds, work with the voluntary sector for additional support. It's most of the obvious things you can think of, but then some additional ones as well, taking the conversation forward about how we look as an alliance at our workforce, at our induction processes, at our well-being. And there've been some really, really brilliant conversations, and supported by Paul and his team, we're also layering the data on top of that going forward, looking at the heat of the system so that we can use it from an operational point of view to be reactive where necessarily, as well as doing the kind of forward planning piece. And I think the feel of the meeting and the kind of dissemination of the information as part of that conversation out to the broader teams at the moment is going very well. So that's a bit of good news. And it feels very different from previous winter conversations, which again, I think is a good accolade for our system. The what are we missing piece of work that we've done to sort of start the conversation more broadly about how we are listening and supporting our communities, our Black, Asian, minority ethnic communities, and more broadly any of the bits of our communities that don't routinely have their voices in the conversations. We've held an event, we've had subsequent, which I've briefed you on before, we've had subsequent meetings since to start to pull out how we work with the community on what our strategy looks like at that locality level, and also the join up with the work that's also going on in East and North East Essex from an ICS footprint. So we just popped the word clouds in there that just gave some of the feel from the discussions to date. We're doing quite a significant piece of work, again linking to Barbara's earlier presentation, around our community health services. We're now several years into the contract being hosted by the hospital, and more broadly being overseen by alliance partners, and it's timely to have a look, building on some feedback that we've had from the community staff themselves about where we go from here. And Leslie Standing from the hospital, and Sandy Robinson and Bernadette Lawrence from Essex County, Suffolk County Council are leading on this piece of work, and it's giving a real voice to our locality, our community teams in our localities about actually what they feel we could be doing differently, and how what integration would look like from their point of view, and also what the gaps are for them, and what we need as an alliance to think is necessary to support them going forward. And when you look at winter and you look at the challenges that are being faced around end of life, and around the challenge that Ed referenced at the beginning of the meeting around the rollout of the vaccine, it's very clear that we need to build as much resilience as possible in our integrated neighbourhood teams, and our community services are a key part of that. We've also put some updates on the pots of funding around the voluntary and community sector that we have on the table. So we've got the Realising Ambitions funding and the community ambitions funding, which are sort of a variation on the same theme. I won't go into the details of the mechanics for that, but in the boxes, in the outline boxes, I've just put in a couple of case studies. So I think just gives you a flavour for some of the pieces that pieces of work with our local voluntary sector organisations that have been supported by these funding streams. And I think they just show, again, talking about community assets and how we are supporting our population in terms of resilience, so that they can sort of have the tools necessary to help themselves in certain situations, and not necessarily always seek for a medical solution to some other issues. I think there's some fantastic examples there. If I just pull out the Home Start for Mid and West Suffolk, which is quite old-fashioned in some ways in its approach, because it is just about giving people time and support with their family life to help them be able to see the wood from the trees sometimes. So support, just being present to help with chores, to help with conversations, to help with understanding how to navigate what is an incredible juggling act at the moment, always, but at the moment particularly with managing a family through a very difficult time. So I'll leave you to read them, but they are fantastic examples, and they're just one of an enormous amount actually we are now collating. And it shows that, I think it shows the benefit of understanding, or gives us some evidence base for understanding how we need to look at the continuation of funding on a more mainstream basis for some of these services going forward. And then the last couple of points are around our Institute of Healthcare Improvement. We've done a significant piece of work with this organisation looking at our quality improvement programme, and we've come up with 4 areas potentially for additional focus: homelessness, people who are struggling with obesity, older people who are socially isolated, and people suffering from mental illness. They're broad brush categories, and there is work going on in each of them. But what we've agreed to do is look at homelessness initially to test out the methodology, and also I think just get that joint ownership piece around how we are supporting this individual cohort of our population. So then finally, Ed's mentioned the vaccine planning, and I think I'd like to just publicly thank our partners and providers for how they've stepped up to this challenge. I think that they've absolutely grabbed it with both hands, and we've had some fantastic collaboration and an enormous amount of work over the last 2 to 3 weeks, in again with a very difficult situation and set of parameters. So I think we're very proud of where we've got to, and have confidence going forward in that area. And then the last point is looking at, as an alliance, our governance review. We're not there yet, but we've started the conversation about what the next stage of alliance working looks like, and that ties into the point that Ed made at the beginning of the meeting around the development of the ICS framework, and how potentially the governance in that wider piece will also be evolved. So once we have a more defined model, it will go through exec, and it will come for discussion, further discussion. We had discussion last week, and then back to governing body. Okay, so that's it for the paper. I'm happy to take any questions. I'll put you all back on screen.
Thank you very much. Any questions for Kate? Lots of good progress in lots of directions. I think Zora might have been first, but I see Ed as well. Zora. And you're on mute as well.
Zora, I can only see your chin.
Thank you.
Okay, really?
Yeah.
Oh, I don't know why. I can see my whole face. Can everyone?
Anyway, sorry, go on, carry on. That's an aside.
Carry on.
I was just going to say, for the purposes of the public, really, that it's all really great work. And as you know, I'm working with the Black and minority ethnic team, not only in West Suffolk, but across, with colleagues from Ipswich and East who are more established. And so because sometimes when you look at all the papers, it almost looks like a paper exercise or political in some way. But just to reassure everybody that actually some really good work has happened. Our event was well attended, and on the back of comments received one evening, I sent a message to our primary care team to say people have found it difficult to access GPs. Can you make sure that practices have a translation tool on their websites? Because I've done some Googling and seen that actually if you can't speak English, it's very difficult to book an appointment online and do the e-consult, and saw that a couple of practices did have translation tools, but lots and lots didn't. And within about a week or two, certainly all the Bury Town practices have got flags on their some multicultural flags on their websites. It's not by all means across the whole patch of West Suffolk, but it's still massively improved from how it was. And we are starting conversations with the college, with the media, and Vicky, who's on our small working group, talked to the patient participation group network yesterday, just in any other business, but we are hoping to planning to run another event in January, and then and then we'll go back to the PPGs and get some community champions again. So it is all, there is real stuff and conversations going on, and actual change has been happening. So that was all really to say, yeah, it's all happening, and thank you everybody for your support.
And thank you, Zora, for the work you're doing and your leadership on it.
Thank you, Ed.
Yeah, thanks, Zora. That was really helpful to listen to, and I think it's crucial that we keep momentum and in the long term on this agenda, and not pick it up and put it down again, which is always the risk. So I'm really encouraged with the work across Suffolk. So I really like these Alliance reports, Kate. They're well written, they're clear, they're very exciting to read if you're interested in matters. My kind of question or comment was around the Realising Ambitions fund. So we've had a fund which was provided to us nationally to use locally, and there's a question about what do we want to continue, what can we afford to continue, if we want to continue, how do we reprioritise given how tight finances is, certainly in the NHS, I'm sure local government too. So it's just to flag, or maybe just to ask you, have you got thoughts about how we have that conversation, because it would be a shame to see the whole programme halt, but counterbalanced against, finances very tight in West Suffolk.
Absolutely. So we've recently had an addition to the finance team. In Jane's team, there's a new deputy, Chris Armit, and we met this week to talk about reinstating, not that it was stood down, but we just haven't had one for a little while, the Alliance Finance Committee. And this was sort of on top of the agenda, along with social prescribing, which is a similar conversation that we also need to have to understand as a system, if we've very openly committed to supporting our voluntary sector organisations and acknowledge the impact that they have and their place in building communities, our asset base in our communities. But the difficult conundrum, as you said, Ed, is what does that look like as a long-term funding piece, and also the conversations with the Future Systems team in the hospital around what role some of these organisations potentially could play in the new model of care as we look at that as a piece of work. So it does all wrap in. So the conversation won't be resolved, but the next step in the conversation is that conversation at the Finance Committee, which hopefully will be in the next month or so. Jane's got a hand up. She will give a lot more detail than that, probably.
So no, I think you've summarised it really well, Kate. But absolutely, we are hoping to get the West Suffolk Alliance Finance Committee back in motion, and to have a meeting hopefully in the next couple of weeks. But just on the more general position, what we are doing as a finance team is I'll come on to it later in the agenda, so I don't want to spoil all the thunder, but we don't as yet know allocations for next year, but hopefully there'll be some favourable announcements in the spending review today, which will give us a little bit of hope for next year. But not, regardless of that, I think we know that the funding scenario for West Suffolk as a system is quite tight at the moment, but we are doing an exercise in the finance team to collect together all of the all of the requests and requirements for next year, and this will obviously be one of those, and we'll need to look at those in the round against the kind of overall resources. I think it's quite important with the community ambitions. We've got a kind of set of things, but it's how we prioritise within those, because I think it's doubtful we'll be able to cover all of them, but it's how we kind of get to a process to know which ones are our, the ones that we're able to support if we've got some funding. But overall, I also wanted to say there's a piece of work going on at ICS level with the voluntary sector to try to develop a more strategic approach, because I think public sector in general has been, and not just in our area, I think it's a national issue, has been quite guilty of, in good times, being able to support a lot of things within the voluntary sector, and it's one of the things that we pull back on quite quickly. And we've got a lot of bits of non-recurrent funding, which obviously creates cliff edges and is quite difficult for the voluntary sector to deal with. So hopefully we will develop a more strategic approach, but I think it's a little way off. In the meantime, we need to just concentrate on what are the kind of priority areas for next year.
Thank you. Paul.
Yeah, thank you. Just to add to what Janet just said, my team are doing some work at the moment to try and understand what are small things we could do to improve sustainability of these services, particularly from a contractual point of view, etc. So that hopefully that will play into the mix and help to support the direction of travel.
Thank you very much. Any further questions on the Alliance? Kate, thank you very much, both for the presentation and for the ongoing work. Linda, the Community Engagement Group and Patient and Public Involvement.
Thank you, Christopher. So I take the paper as read, but just would go through a couple of points. We are continuing to meet virtually every month, and that seems to maintain contact with our volunteers on the Community Engagement Group and helps us to react and share information or their questions more rapidly than perhaps infrequent meetings. So it is working well at the moment. You see some of the issues in the paper that have been raised by our members, and it's really good to see in our conversations, although not in this paper, we have talked quite a lot about the trusted assessor and the importance of carrying out an assessment once and then people believing in it and communicating it on. And I see that's in the commissioning intention paper later on, which is excellent. It is raised here in the paper. We were concerned about some issues to do with obesity, and I see that that's one of the highlights also in the West Suffolk Alliance, as are working and caring for those that are socially isolated. And some of the conversations that has happened with Barbara and in the meeting so far is the importance of the community wrapping around people that need support, and equipping them and supporting them to be able to give that support, where the professional contact is perhaps 5 or 10% for health and healthcare support for people in the community. So it is really supporting the communities and how we can wrap round the professional support. One of the issues that's also come up is around the integration and communication between health and social care, whether it's in the discharge process from hospital or ongoing care, whether care records are left in the person's home rather than taken with the carer. There's all sorts of issues that are coming up that we are sharing with the relevant people within the CCG to take that forward. So it seems that the voices and the communication from our volunteers are being fed back into the CCG, and we're getting some very helpful responses back. And it's excellent in terms of the mental health work that we see, again, work moving towards the 111-2, but also from the information this morning that the rapid response has done such an excellent job with 25,000, was it, responses or calls so far, which is, excellent. The other issue to raise is perhaps that the PPGs are being offered more support in the area, and there's a network that is being established, and we've had the first meeting this week to try and re-establish that network and support the PPGs, support the practices moving forward. And I think unless there are, you can see in the paper where the speakers that we've had come to give us an update on mental health, and also the actions and the roles that our members have taken in terms of supporting either interviews or various meetings. So just happy to take questions on that. Thank you.
Kate.
I was just going to add, I think that I thank you, because I think Linda's pulled off something quite difficult in terms of taking the CEG online and having a lot of the conversations in a different way. And we've got a new pair of hands to the pump, haven't we, Linda,
Yes.
in Sophie, who at some point will probably get to the board or to exec as a minimum to introduce herself and to just talk through some of her thinking on where we go from here. But I think it's a very timely appointment, isn't it, in terms of Linda and I have talked a lot about needing to do the join up piece with the different bits of engagement that we have across the Alliance patch, and we've never quite had the capacity to achieve it. So I'm very hopeful going forward that Sophie's going to bring a new level of energy.
Thank you, Kate. Yes, that was the bit that I should have mentioned earlier, that is really exciting, her post and her vision, and how well she is listening to the different parties in alliances and across the ICS. So that would be really exciting to see how we can communicate and how we can join up the voice of the public and the citizen in different situations. Absolutely. Yeah. Thank you.
Thank you, Jeff.
Thank you, Chair. Thanks, Linda, for that presentation and a good report. I just wanted to point out or emphasise the issue on the communication in the table, and hope we do take that on board across all reports, these acronyms to the public. I think it's a really important issue, because there's more and more of them creeping into papers, and it's getting more difficult to understand them. So I think that is key. And I think I met Lynn Byrne only last week, and I think she was saying the same thing to me at Newmarket locality. So thank you.
Jeff, I think that's a really valuable point. I think that we deliberately try with the Alliance report to keep the English as plain as possible, and we don't necessarily always achieve that. But I think that across the board, as this is a public meeting, all of the papers almost need to have that kind of sense check to it. So again, perhaps that's something that we could explore separately.
Thank you. Linda, thank you very much indeed. Richard, the commissioning intentions for the forthcoming year.
Thank you, Chair. I'll get my excuse in now, Jeff. Apologies if there are lots of words that aren't plain English, but the good news is we are commissioning a Healthwatch Suffolk and Healthwatch Essex to write an easy-read, public-facing version of our commissioning intentions, which I think will be really, really helpful. So just by way of background, every year we need to produce a set of commissioning intentions as a clinical commissioning group. Last year we produced ours in the West in tandem with Ipswich and East. And this year, for the first time, we've made the decision to develop a set of commissioning intentions across the 3 clinical commissioning groups, so including North East Essex, given the significant amount of joint work that we are now doing as a set of 3 CCGs. The second thing is building on the way we've approached these over the last 2 years. We've moved away from a traditional set of commissioning intentions, which are driven by a contractual and financial bent, insofar as they set out some of the specific line-by-line changes that we would expect, or vice versa with our providers, to what you see here, which is effectively setting out state of the nation almost across Suffolk and North East Essex around the main system architecture that we've got in place, our integrated care system, our alliances, our localities, etc., and then setting out some of the detail of the specific programmes that we've got running. So if I can, Chris, just briefly running through the section 2 of the covering report, which for those colleagues who haven't managed yet to potentially read the significant 42-page document, I think the summarised version gives you the main headlines you'll be glad to know, and we'll be using, Healthwatch will be using this to base its even shorter version on. So the document starts really with setting out what is our integrated care system, and importantly it takes its starting point as what we've experienced over the last 7 months around our COVID-19 response and our recovery work. And it takes the 10 lessons or themes that has come out of that report that we considered a few months ago around what are the lessons that partners, the public and others have felt. And that's really then how we ensure that through our work over the next financial year, we learn through those lessons, include those within our work. We've also then led with our health equality driver. So that's the golden thread that's running through our ICS strategy and our Alliance strategy and plan around how do we tackle health inequalities. And it's set out there the 8 high impact actions that NHS England have set nationally, which we're in the process of adopting locally and working through. But it also importantly includes a section around the important role of the voluntary care sector within the work that we've got underway, and some of the things and the themes that we are working with them and which we'll build on next year. There's then a significant section rightly around our alliances. So you'll see if you've read that section, there's a lot of commonality across our 3 alliances, but also some key differences. So we felt it was important to set out particularly what our 3 alliances were looking to deliver over the coming financial year. Equally importantly to that, we also touch on our localities and particularly our drive to really devolve down responsibility where appropriate down to our locality level. So that's the 50k roughly head of population, the 6 we've got in West Suffolk, and continuing to build on our local delivery plans we've got for each of those 6 local areas. We've got a small section, given it's our CCG commissioning intentions, on CCGs, and that really confirms the changes that were made last year around moving to 1 chief executive, 1 management team, but also a nod to the fact that we are currently considering any further changes in our governance that we're looking to make as we build on our 3 alliances, and we look further to how we can work even more jointly across our 3 clinical commissioning groups. It also touches on the primary care networks, which we, for the first time, included last year in their formation, but particularly I think this year, they're going to be an even bigger feature of how we approach our transformation and commissioning work. And you'll see there's a number of specific items that Kate and Lois and colleagues are leading on with our primary care networks. We've got a small section then on aligning incentives to deliver change, which sounds jargonistic, but effectively it's how do we use our finance and our contracting routes to affect and continue to deliver change. So one of the biggest changes we know we made, I can't remember now, about 4 years ago, was moving away from payment by results. So paying on the basis of activity to looking at how we base it more on actual cost and how we effectively align our incentives to make some of the big changes we've managed to achieve. We're looking to continue to build on that in 21-22, but that section is deliberately short because we have not yet received what's being called phase 4 guidance from NHS England. So that's effectively building on the work we've been doing through the last 8 months around what's the national expectations in both finance, contracting and transformation linked to the national long-term plan from 21-22 onwards. So it's likely that and indeed all of this will be slightly moving feast as we continue to evolve and adapt to what we're experiencing through COVID and some of the guidance that will be coming down from NHS England. The rest of the document basically goes through, as I said earlier, the main transformation programmes that we've got underway. So there won't be too many surprises, if any, I'm hoping, for colleagues there. And indeed, when I've taken this to the 11 committees across the ICS to run this through with our alliances, our voluntary care sector, our ICS programme board, other than the odd small addition, generally there's a consensus that it does cover the main things that we're running or operating either across the ICS, the county-based, or the alliances, or indeed localities. And then it concludes importantly with our 3 enablers: workforce, digital and estates, setting out some of the main headlines around those. So Chair, I'll leave it there just to say, as I said, we are looking to do a shorter version with Health Watch, and subject to the 3 governing bodies, we've got North East next week, we'll then be writing formally out to our providers with our commissioning intentions. But effectively, they've all seen it many times over the last 3 to 4 weeks. So I'm not expecting there to be too many issues. Thank you.
Thank you very much. Any questions for Richard? Ed?
So I was just reflecting on Zora's comments and Kate's comments earlier about the work we're doing with our BAME communities, and that there is wording in the document about that particular priority. But I wonder whether we just need to emphasise that a little bit more, just because there's a lot in there, isn't there? And that particular issue is one amongst many. But I wondered, because it is a big priority for all of us, to just whether we just double check whether we want to put a bit more wording in or change the tone of the emphasis.
Yeah, as the letter's coming from you, Ed, we can make some of those changes. Absolutely happy to. There is, as you said, in the longer version, there is a section related to some of that, but we can bring that more out or to the front in terms of the summary.
Thank you. Any further? Richard, thank you.
No problem.
Paul, the procurement update.
Yeah, thank you. The paper is to note, so I won't go through it in detail, but I will pull out 2 or 3 things, if I may, Chair. Just again to reiterate that the stroke work is ongoing. We're moving to mobilisation, which is great news. In terms of pathology, we've now agreed an approach to procurement, so the work will be starting in earnest in terms of developing the approach going forward. I think there are probably 2 other things: the mental health transformation, which I'm sure Richard will pick up through the transformational piece on IPR, and the CYP neurodevelopmental work, which is also starting. I would just make one observation. As we are working through our procurement processes, it's becoming very evident, very clear that we are starting to move to a much more collaborative way of procuring. So we are now starting to invite the system to work with us to develop services, which is essentially a commercial type procurement. Slate takes slightly longer, but ends up with a far better outcome in terms of service provision. So I would just make that point that for those of you that are detail-minded, we'll start to notice, I think, that we are more and more starting to take that approach. Other than that, I'll take the paper as read and happy to try and answer any questions.
Thank you. Are there any questions for Paul? Okay, I think it's read and received, Paul. Thank you very much. Which takes, oh, no. Sorry, questions now arisen. Jeff first, please.
Thank you. Yes, thank you, Chair. Paul, when's the procurement board going to be sorted out and up and running, please?
Yeah, that's a very good question, Jeff. My team are clearly working on that at the moment. I haven't yet a time scale, but I will work on it and come back to the board.
Thank you.
Kate, you had one, but you thought better of it?
Oh, it was just a comment, just to say how welcome the approach is around the co-production piece. I think that is absolutely in line with the conversations we're trying to have in terms of ownership of how we develop services amongst our provider base.
Okay, thank you. Paul, still with you, the emergency planning resilience and response audit.
Okay, thank you, Chair. So by way of context, we're required as a governing body to note the progress on EPRR status. We were written on the 4th of September by an HSC setting out the approach that we would be taking this year. And it's fair to say we were advised this should be light touch comparative to other years. So essentially, this meant a review of the 1920 plans, with a view of whether or not the organizations themselves had plans going forward, and that's where essentially the assurance stopped. So that work has been undertaken, and you will see that we are substantially assured throughout all of the areas. The only difference I would point out is the element around Practice Plus group was a nationally led element of that, and it clearly moved from essentially non-assured to substantially assured, but that was done on a national level, and that's what we are duty bound to report. The only reason that we are not fully assured at the moment as a CCG is because we remained with one policy that we're currently working on to make sure we standardize the policy, if you want, across all 3 CCGs, and that work is ongoing. But essentially a pretty good report in terms of where we are. The last thing I'd like to say is my apologies, but I think third column should probably read 2021, not 1920. That's a typo which we will change accordingly. So essentially, we just have to note the work that is ongoing through EPRR, and that work continues.
Thank you very much. Any questions?
Linda.
Linda?
Thank you very much for that, Paul. Can I just ask for a clarification of the different levels? Substantial, partial, substantial. What are the levels in the assessment?
So essentially, there are 3 or 4 categories of assurances. Fully assured is essentially you've done absolutely everything. You've got all the plans in place. You've communicated the plan. You've road tested the plans. You've done absolutely everything. Substantially assured is essentially you've got all the right things in place, but there might be some elements you haven't quite completed. And then there are 2 other sections. Forgive me. The last section is unassured, which is you've really not done very much about it. And then the second one is you've started it but actually haven't come to fruition. Essentially, that's the definition of the four levels.
Okay, thank you.
Thank you very much. Any further? Thank you. Lisa, on to item 13, please, the Special Educational Needs Annual Report.
Thank you. So this is the annual report for 1920. You'll note that from the report with all the logos on the top, it's a report that's done jointly and goes through all our joint board processes. So there's one report. That was something that was recommended to us from Ofsted and CQC, that we had one system annual report rather than separate health, social care, education reports. So this is the first joint report that we're all taking through. We've taken this to clinical scrutiny and had a good discussion about it. It's really coming to the governing body just for information. But it does detail all the achievements that we've made against our current strategy. It gives an overview of the governance arrangements, which you will remember was raised as part of by the initial visit by CQC and Ofsted as an area to improve on. So we do feel that we have really robust governance arrangements now within the SEND programme. The report details the areas that's gone well, including funding and commissioning intentions, and you can see from that chapter actually how much funding has gone into improving the lives for children and young people with SEND in Suffolk. And it also talks about current concerns and areas that we are looking at: permanent exclusions for children with special educational needs or with an EHC being a key element of it. And we are actually also looking at the moment at fixed term exclusions as well, because that's a concern to the SEND programme board. We also know the areas that we need to continue, and in particular we're very focused on developing the strategy for 2021 for the next 3 years. We started that pre-COVID. We started with a self-assessment event, but that has had to be paused during COVID because obviously the education teams that are really important to developing the strategy have had their attention focused elsewhere to support families during COVID. But we are kind of entering into developing the new strategy with enthusiasm, because we would like to get our new strategy by the end of March. So we would like all your involvement and engagement in that, because it's really important that it's co-produced with users, families, but also with frontline staff, including primary care that often are talking to families with children with SEND and know some of the impact and outcomes that they see in these families. So, and in particular, we need to make sure that we are working with the strategy to be able to demonstrate impact and outcome, because we have at the moment, a lot of process measures, a lot of measures that talk about access, that talk about the timeliness of education and healthcare plans. Ed referred in his opening comments about the great work that we've done to make sure that people that young people get a plan in a timely way, but actually we need to be focusing on what's the quality of that plan. Are the outcomes achieved that were set out in that plan, and how are we capturing the impact of that plan through the annual review process? So much more focus on outcome measures. But I'll leave it there because I'm sure you've all read the report. Thank you.
Thank you very much. Are there any questions for Lisa? Jeff.
Thanks, Lisa. Excellent report. Good amount of information there, and we're on progress. Could I just ask, you can send me this offline if you want. Who's on the oversight board if I'm non-execs and lay members, please?
So that's a really good point that you raise, Jeff, because it is Steve Chicken, and actually Send Oversight Board was on Monday, and I did take an action to discuss how we take that forward. Actually, as Steve hasn't been very well, how we manage that going forward. Mark Shenton is also sits on the board.
Okay, thank you.
Kate.
I was just going to ask, where else is this being seen or being sort of published, Lisa? There's so much. Where are you there? There's so much amazing intelligence in the paper. I learned quite a lot from reading it, and especially around investment and the kind of areas of progress. I don't think that people really recognise the volume of work or the kind of forensic attention that's been given. So it would be nice to be able to kind of make sure that we're blowing the trumpet as much as possible.
Yeah, possibly not. We haven't possibly done that enough, Kate. So we've taken it through. So it's going to Cabinet in Suffolk County Council. SPCN have taken it through our board, through their board. It will go on the website once it's been through all the governance processes. But there probably is a bit more that we could do to make sure that everybody understands the amount of work that has been done.
I'll give it some thought as well from our system point of view as well. Yeah,
that'd be great.
Thank you. Linda?
Thank you. Some excellent work, lots of progress, isn't there, in this area? Thank you so much for the report. Just one small question, and perhaps building on where is the report seen in terms of education as well, because I was amazed that the amount of youngsters 16 to 25 that are in employment, education or training. And I see from the report that it might be a data issue, and that there are all sorts of confusing data perhaps with the furlough and whatever. But a lot of that comes down to confidence and opportunity and encouragement, doesn't it? Which sometimes is really difficult to say, yes, this professional will do that. It's perhaps more the community and the support around them. And I just wondered how that was being developed and taken forward in terms of encouraging more of those youngsters to be within the education, employment and training area.
And I think that will be part of the new strategy, a real focus, Linda, on the new strategy. As Ed said, we are starting to do some great work on transition. It is a priority area, it's a priority work stream. They have produced, as I said, the transition guide, which is an empowering document that tells young people and their families what they should be able to access, what they can demand as part of their transition in health, social care and education. It's a system transition guide. We've got quite a bit of work to do in health, if I'm honest. We're about to start benchmarking our providers against transition requirements in all there's lots of best practice guidance from Nife and a variety of places. But I think that transition period and the young adult is one that we will need to focus on going forward.
Happy to help. Thank you.
Thank you very much. Any further? No? Right. Lisa, again, please, the situation with COVID vaccination.
Thank you. So we thought we'd do a verbal update because things change, as we all know, daily with COVID and mass vaccination. So I was just going to give 2 updates, and I'm sure some of my colleagues who are working a lot on the programs may also want to update. But just to remind the board of some of the stats. Actually, at the 21st of November, there had been 6,722 cases of COVID-19 in Suffolk and 883 cases of COVID-19 per 100,000 population, which is the lowest rate in the east of England. So actually Suffolk is doing extremely well with COVID-19 infection. So the 2 areas that we were just going to update you on, firstly, is the outbreak data and the oversight arrangements in health and care settings. And then secondly, just a general broad update on COVID vaccination programme. So we have seen an increase in outbreaks, both in the health and the care sector, particularly over the last 2 months. As it stands today in Suffolk, as a total, we have 13 outbreaks in care homes, 9 of which are in Ipswich and East and 4 in West Suffolk. We have a really structured process to review all outbreaks with Suffolk County Council and the care home team. And you'll remember the infection prevention team, we invested in the increasing the numbers within our infection prevention teams to be able to support the care home teams alongside the integrated neighbourhood team and the community nursing response. So we have a really good process to review the outbreaks, ensure that people are remaining safe and oversee the actions that are taken by care homes, and then keep in touch with the care homes, making sure that they've had their IPC training update, and if there are any actions that they need support with, we support them with that. West Suffolk Hospital, have had a number of outbreaks. It's fairly low in the scheme of things when you look at the level of outbreaks and the number of people that have been affected in West Suffolk Hospital. They're not an area of concern in the east of England at all. And the main causes for some of the issues at West Suffolk is around their estate, lack of side rooms, bays that have closed doors. That's not an unusual picture, again, across many of the hospitals in the east of England, but that's one of the themes that come through. The other theme that comes through is around asymptomatic staff. So as Ed said, both providers, ESNEFT and West Suffolk, have received the lateral flow tests. So we're really hoping that by test, we will see less outbreaks as we go forward. The other area just to update is the system response to the mass COVID vaccination programme, and you will be aware that Essex Partnership University Trust were appointed as the lead provider to lead the programme across Suffolk and North East Essex in collaboration with us as a system. So at the moment we have 3 vaccines that have been developed with promising efficacy, the Pfizer, Moderna, and the 3rd vaccine, the Oxford AstraZeneca vaccine, is showing some good results. We have a national model around how we will be delivering the vaccinations. So there will be fixed mass vaccination centres. There will be mobile centres, and we will be getting support through primary care and a roving service. So in Suffolk, we've been working hard to make sure that we're in a position to start vaccinating as soon as we receive the vaccine. We have been asked to get the first site up and running by the 1st of December. And I'm really pleased to report that we're on track with that. As you can imagine, workforce has been an issue. We have a workforce bureau that has been established across Suffolk and North East Essex, working with EPUT, and that has seen quite a significant number of applications from nurses, admin and volunteer stewards. So we are confident that we'll have the first site running by the 1st of December. That doesn't mean we'll have the vaccine, but we will be ready to deploy as soon as the vaccine is licensed. And Kate might want to come on to talk about primary care, because obviously primary care are also working incredibly hard to make sure that they are ready once we all get the go ahead. The planned targeting of priority groups isn't finally defined. We thought it was finally defined, but it's slightly changed, and it is dependent on the vaccine that we get, which again we're waiting for national direction on. So I think that's probably the only things that I was going to raise. We have a really good governance process. We have 3 times weekly operational meetings where the work stream leads, workforce, primary care, IT. We have a health inequalities work stream that Susanna Howard is leading to make sure that the placements of the sites and everything that we do is having an equality impact assessment to make sure that we don't worsen any inequalities through our work on the COVID vaccine. And we also have a board which EPUT chair that was yesterday, is always on a Tuesday evening, which we have a deep dive into one of the work streams, the highest risk work stream, and then an update from other work stream leads. So it's been a huge piece of work that has had to happen really quickly. And I think Kate was saying at the beginning how amazing the response that we've had from partners, and how primary care in the West has really galvanised itself and risen to the challenge, because I think it's a real honour to be able to deliver this COVID vaccination programme. It's the one thing that's going to get us out of the sticky wicket that we're in, and actually I feel very proud to be involved with it, because it's the thing that's going to save lives and keep us all safe. So thank you. That's my little bit of spiel. I don't know if Kate wants to add anything.
Kate?
I can do. I'm going to start by adding, I feel I've done this loads today, I'm a bit of a crack record, but a thank you to Lisa, because she's picked up the SRO for this, as she does with all the best jobs during this global pandemic, and has done a brilliant job with a smile on her face. I'm not necessarily going to say it again. I think that from a primary care point of view, it's been a fantastic shop window for the strength of our primary care within West Suffolk and across the whole ICS, if I'm being honest. And we've got 3 clinical directors from our primary care networks on our board. I don't know if there's any to invite any observations from any of you. I'd say, or acknowledging that it's been challenging, acknowledging the goalposts have moved several times, but from your point of view, is there anything you'd like to add?
Well, I will if you like. I mean, there was a time when the goalposts were moving about twice a day, and most of the PCNs responded to that. The plans were ambitious, particularly given the rather unstable nature of the first proposed vaccine. Mercifully, my understanding is that we've now been relieved of the administration of that rather unstable vaccine, and when we get into the game, the vaccine being issued will be a more stable one, which we can transport in near normal conditions and take round to the care homes and housebound patients, and then presumably start our own vaccination sites for the groups that we've been targeted with. Barbara?
Yes, thank you, Christopher. I also wanted to make a comment about primary care embracing this, although with all the difficulties and the workload that we're already facing, everybody realised that this is something that we have to actually do, because it's in the best interest of our patients and in the whole community. And also, as Elisa said, I don't know, was it Kate, that this is the only way out of this crisis, so we all have to work hard.
Thank you.
Thank you.
Andy?
Yeah, I just wanted to reiterate the endorsement of West Suffolk and primary and ICS primary care, but particularly West Suffolk, which we should never hold in any doubt. I've always alleged that it is a superb organisation, but I would also like to just flag up how one of the great things we have done over the years as a CCG and as a system has been to have great communication with primary care, which through Lois and her team has been better than it's ever been. And COVID has a habit of testing dysfunction. If you've got a dysfunctional part of your system, COVID will find it out. And I think what we've shown is that with this primary care and with Lois's work, we are supremely functional. And actually, we've done as far as well as we can possibly go with her work. And I just want to endorse Lois's team. Thank you.
Absolutely.
Thank you. Firas?
Thank you. I agree with you, Christopher and Barbara, what they said earlier. Just a quick question, Lisa. Do we have a plan for a mass site in the West currently?
So we don't have anything signed on a dotted line for us, but we have certainly we have 16 sites that we are looking at beyond the first site. So we will be looking at setting up 17 altogether, and we certainly have some that we're exploring. Well, they will be geographically placed to make sure that everybody has equity of access to these sites. So nothing signed, sealed and delivered yet, but good plans.
Thank you.
Thank you. Right, well, thank you very much, everybody. We now move on to the section Finance, Performance and Scrutiny. Those of you who have been sat there for some time, there will be a break, and I'll aim to have it about 10 past 11 or so, but let's see if we can make some headway in this section first. So Jane, the forthcoming budget for the second half of the financial year, please.
Yes, thank you, Chair. So the paper presented, as you can see from the title, is looking at the budget for the period from October to March for this financial year. I know that members of the governing body are very familiar, but just for members of the public who might be listening in, it has been quite an unusual year for NHS finances this year. So in the period from the announcements of the pandemic and the emergency regime, we've been working in a very centrally mandated financial situation whereby the NHS has been provided with resources to do what it's needed to do as far as the pandemic goes, and there's been a central system of claims and top-ups in place in order to help the NHS to do that. That came to an end at the end of September, and what we're returning to in the second half of the year is a sort of a hybrid between a business as usual, whereby the CCG receives allocations and makes contracts with the rest of the NHS. That's what we would do in a business as usual world. In this sort of hybrid world, we've been given an allocation, although that's been supplemented in a number of ways as set out in the paper. There are additional resources for COVID and an additional small amount of money for growth, which I'll come on to. But a lot of the financial regime that we're working within is fixed. So for the first part of the year, the payments to our main providers for West Suffolk, that being West Suffolk Hospital and our colleagues in mental health in Norfolk and Suffolk Foundation Trust, those payments are fixed. So whilst we do have an allocation and more freedom to work within, we don't have the usual ability to move things around, and hence it's a slightly hybrid situation. So I'm not going to go through the paper in huge amounts of detail because the Finance Performance Committee spent quite a lot of time looking at this at its meeting in the last couple of weeks. What we presented to that committee was the fact that when we pulled together the expected expenditure for the remainder of the year and the allocated resources, there was potentially a gap for West Suffolk CCG of around about 4 million. The Finance Committee sent the team away to do more work on that, and we have done quite a bit of work just refining some of the growth allocations, looking at our brought forward accruals, etc., and we have managed to close that gap down to the 2.9 million as presented in the paper. That revised plan has been submitted to NHS England, our regulator, and whilst we've not had a formal acceptance of that, we also haven't had any requests to change that at this point. So it's a kind of a a position that the regional office are comfortable with at this stage. However, we know that there's further work to do on this, and as set out in the paper, we'll continue within the CCG to look at areas where there are further technical adjustments and efficiencies that can be made. But we are also now starting to raise that within our West Suffolk Alliance, which is our first step. And hopefully, as we mentioned earlier, the West Suffolk Alliance Committee, we can get a date that's suitable for the hospital colleagues, etc., will happen in the next couple of weeks. If the Alliance is not able to contribute in any significant way, that will then be raised to the ICS, because overall the requirement will be for our overall system to try to live within its overall resources. So we will be looking for potential support, but that most likely to be sort of slight improvements on plan from our other system partners. So what's presented in here is a budget that shows the allocations that we're receiving as a CCG. It gives a breakdown of how we're planning to spend those across the main expenditure headings. And as you say in the paper, it does give us a shortfall, but I just wanted to reassure the governing body that we will be working hard to try to bring that in on balance as best we can by the end of the year. The paper goes on just in terms of things to note, that what this budget doesn't do is what this budget excludes are a number of things that have been announced recently. So things are moving very quickly, as we heard earlier, in terms of mass vaccination, and we anticipate quite significant costs around those. But we have been given assurance from region that those will be funded separately, so they're not included within here. Neither is the recent announcement about additional funding for primary care, which is subject to a separate allocation, or anything that comes out in the spending review today, although that's more likely to be looking at the 21-22 financial year. So this is a kind of an ongoing budget, picking up those elements for our key areas. It does include an allocation for COVID costs, which you can see in there, and it also includes the system growth funding. So within the allocations we were given, each system was given approximately 0.5% called growth. Now, it's effectively a small amount of funding to deal with any issues that weren't in the original plan. So you can see that in the appendix we've given the breakdown of how that will how we're proposing to allocate that for West Suffolk. And what it's doing is a combination of things. It's trying to continue a lot of the items that we put in place in the first part of the year. The most significant, Barbara spoke about earlier, around the end of life services, which the hospice have stepped up and really, really supported the system. What we're doing is trying to continue that through the growth funding for the second part of the year. We're also picking up areas where there are national initiatives that we need to put in place, like the Think 111 service, where the funding for that is insufficient to cover the costs. So effectively, sort of topping up the rest. So the remainder really is to look at those kind of ongoing pressures within the system, both within the hospital and within the CCG, that we anticipate, and you'll see that in the appendix in terms of the growth funding. So that's all I wanted to say on the finances themselves. Obviously, at the end, I'll be happy to take any questions on that. But before I do so, just to point another couple of things out that I've put into the paper rather than write separate papers on this time. At the governing body, we have looked at our previous meetings some measures that we've put in place to help the system to get through and make quick decisions associated with the times the unprecedented times that we're in. So I'm asking through this paper that we extend the joint committee we put in place, the COVID approval, I should say, the COVID approval committee, the CRAC committee. We're asking to extend that until the end of March. We've been rolling it on a bi-monthly basis, but I think it's better for us just to assume that we will have quick decisions to make by the end of the year, and so to extend that until the end of March. Just to give assurance on that, the minutes for that committee all come to the governing body, and the finance committee does scrutinise all the decisions that are made as part of that committee. So hopefully you're getting coverage around any decisions that are made, and to accompany that CRAC committee and that those decisions that we do need to make at short notice. I'm asking the governing body if we can extend the changes to the scheme of delegation again until the end of March. They're set out in the paper. They are in line with our other CCGs across the patch. and governing bodies should rest assured that we only use those where we absolutely have to. We stick with our usual sign-off levels for all business as usual decisions, and just as you would expect us to. So that's really the paper in a nutshell, and I'm happy to take any questions, Chair.
Thank you very much, Jane. Are there any questions? Barham?
Yes, thank you, Jane, for your excellent report. Can I just ask, you mentioned there's been a change in terms of how much we're going to save from the last time we had a meeting. Where are the main areas of savings that has been identified?
So you'll remember at the Finance Committee we said that we would do a look through of all the assumptions that we had made in terms of both how the growth was allocated and in terms of looking back at any accruals, sort of prior year provisions that we've got in place. They've effectively come from those. So they're not any change in terms of service provision. They're really more of a kind of tidying up and releasing any items that we could from the balance sheet.
Fantastic, thank you.
Thank you. Jeff?
Thank you, Jane. Thanks, Jane. Thanks for a very clear paper. Couple of points. Have we had any indication from the region whether there might be any more money coming to our system or our alliance? And secondly, I'm happy to support the recommendation about the CRAC committee and the delegations. Thank you.
Thank you. In terms of your first question, first point, Jeff, we continue to get updated allocations each month, and the month 8 ones are due imminently. We've had a few small changes in allocations which have worked in the CCG's favour, but nothing major yet. We've got a CFO's meeting on Friday, which will be asking lots of questions, particularly around the funding for mass vaccination and the announced primary care monies. So we'll be able to update after that.
And has there been any changes to the hospital position? Because again, that's part of the system deficit as well, isn't it?
It is. So no, there haven't been any changes to the hospital position, but I spoke to the hospital director of finance yesterday, and he assured me that they are aiming to break even, although they are showing a small deficit at the moment.
Thank you.
Thank you.
Are there any more questions? Is there anybody who is not happy to support Jane's 2 requests, 1 for the continuation of the CRAC committee and 2 for the continuation of the delegated budget arrangements? All happy? Unanimous. Thank you, Jane. Thank you very much. Now we'll move on to the integrated performance report and do 1 or 2 sections before we have a break. First section, Lisa.
I think Paul normally does a.
Yeah.
Okay. Right.
I can. It's a complicated report. I totally accept okay. That. If I may, I mean it is quite a lengthy and quite detailed report. So if I may, Chair, I sort of take the report as read, but like to pull out a few bits if that's okay of observations, and then I'm sure both Lisa and Richard will probably want to come in and possibly Jane around some of the other elements of the report. So I think if you start with the CCG performance element, you'll certainly notice that from an 18 weeks point of view, there's been a slight improvement. 52 weeks is slightly worse, but there is some evidence that things are slowing down in terms of the rising number of over 52-week patients. There's some slight improvement in diagnostics, but really the main issue remains endoscopy. Now, by way of context, it's really important to view this report as month 6, which is September. And as you know, phase 3 has been running in parallel. And part of the work that West Suffolk FT have been doing is to increase their capacity around elective diagnostics, etc. So in terms of electives, Suffolk are carrying on to improve with about 76%, although the target is about 90%. The diagnostic of MRI is now up to 84%, CT 96%, and endoscopy is improved slightly to 72%. It's fair to say that there will be some additional CT and MRI capacity coming online pretty soon. CT pretty imminent, and MRI I think in January. So again, the other element of context of this information is that we are starting to increasingly look at performance through not only the lens of COVID, but the lens of winter pressures, the lens of workforce, and we've heard a lot about vaccination and workforce and outbreaks and all those issues. So clearly, many of the plan that we got sitting around the performance plan are what helps to support performance. And I think it's credit to all the work that's going on that performance has been maintained the way it is at the moment, given the many challenges that I think that the system, West Suffolk FT in particular, are facing. If you look at cancer, there's clearly a bit of deterioration around 2 weeks. The main issue, as you'll spot, West Suffolk FT is 65%. The main reason for that is linked to diagnostic endoscopy and a symptom of direct to test. So absolutely the right pathway, get the patient to diagnostics first, and then obviously to treatment and discussions. Clearly, having this post in place whilst you are challenged with endoscopy is a problem, and the trust are currently working on that at the moment with some new leadership around plans to try and address some of the issues. And as I said previously, things are slightly improving on the endoscopy front. Overall, 31 days is holding pretty steady. But you'll note that elective activity is clearly an issue around that element, which is clearly linked directly to capacity. But again, the trusts are carrying on to prioritize urgent care and making sure that the most needy patient end up with the right treatment. And finally, 62 days, slightly worse. But again, I would predict that as trusts are trying to work through their backlog, we may see a worsening of that position, which is absolutely the right thing, because as more patients you treat have been waiting long term, that denominator will get slightly worse. The only other thing I'd like to pull out of the report, NSFT, I think on broadly are carrying on their upward improvement. I think most of the KPIs are holding fairly steady, but like to point to the 4-hour crisis, which is improving, and the 15-week referral to treatment is also improving, and it's clearly underpinned by quite a wide transformational program on mental health, which I'm sure Richard would be happy to talk to. The only other element really for me is ESEC. You see there is some slight deterioration in transport and issues, and we are currently having discussion how we can support that by putting some additional capacity, particularly in accepting that COVID and the number of patients you might be able to put on any one transport is now limited, and we are looking to address that issue as we speak. So again, we have been hugely supportive of that service to make sure we have the right level of transport in a timely fashion to our patients. So I'm going to stop there and sort of see whether Lisa or Richard want to come in on some of the particular aspect of quality and transformation.
Thank you, Paul. So Richard and I kind of do a bit of a double act now. So from West Suffolk's position, obviously from a quality point of view, as you can imagine, the areas that we are really supporting and working with them on is around their outbreaks, and making sure that the right IPC pathways are in place. One of the key areas of concern for West Suffolk has been that they haven't been able to recruit to an infection control lead, despite four recruitment tries. So they do require some support from my team around IPC, but they are doing incredibly well, actually. The other area you'll see on the provider on a page, actually we mustn't forget the other elements of IPC. So we mustn't forget C. difficile, MSSA bacteremia and E. coli bacteremia. And again, those processes are still continuing to make sure that the work is ongoing to improve those, and the RCA oversight where required. So just to give you that assurance. The other big thing that we're tracking for West Suffolk, and we talked about on the joint oversight meeting with NHSEI yesterday, was their flu vaccination rate for their staff. So the East of England average is 63.1% as of the 18th of November. That's probably being updated today, but The last data I have from West Suffolk is that their data is sat at 58.9%. Now, of that, they have done 70% of their frontline workforce. So it's the frontline workforce are doing really well, but actually there is a requirement to have achieved 90% by the end of the month. So they are quite a way off. And as you'll know, it's important that we get our frontline staff and all staff vaccinated for flu before we start to deploy the COVID vaccination. From a quality assurance point of view, we've talked previously about the maternity oversight, and that continues, joint oversight between us and NHSEI. We have a joint meeting this week to look at their plans for rollout of continuity of carer, which they have now started to roll out in West Suffolk. They started last weekend, so we'll get an update about that, but that's really positive. They are meeting birth rate plus ratios, which is the workforce modelling that you use to make sure that you've got safe staffing in maternity services. But because they are a smaller unit, birth rate plus numbers don't seem to match the numbers required for continuity of carer. So they are working on a business case for looking at an increased midwifery establishment to be able to take forward continuity of carer. And we did a meds management quality assurance visit, which was very positive around the improvements they've made for safe storage of meds management. And the next visit that we've got 2 visits planned. One is to look at the support for patients with learning disabilities and their mental capacity assessment process, and that has stemmed from some concerns we've had where we've had to intervene with support to the trust because their processes have not been as robust as we would like. And the second review that we plan to do, now we've got a children's lead in my team, we're going to do some quality assurance visits of their community paediatric team, because again, it's great they got good in their CQC visit, but just some intelligence that we have around their ability to deliver their care plans for children with CHC, we would just like to go and test that and make sure the care plans are robust. I think that's everything. I'll hand over to Richard.
Thank you very much, Lisa. So Kate's already taken us through some of the main headlines from the West Suffolk Alliance programme. Just a couple of things to add to that. So a lot of the focus over the last 6 weeks or so has been working with the Acute Hospital Community Services, the Council and Paul's team to look at what additional capacity can we try and bring on stream to support over the winter period, partly as a result of winter pressures, but also as a result of the ongoing COVID-19 pandemic. So we have, as you may know, commissioned additional capacity at Marham House. We did that in July. We've extended that to the end of the financial year. We've also agreed to create another 20 beds, or effectively commission another 20 beds jointly with Suffolk County Council over in the west of the county to support the hospital as well, temporarily again until the end of March. And we've also agreed to extend the virtual ward model that Sandy and Leslie over at the community provider have been working through. So they're all additional helpful capacity that we need to support over the next 6 months. Moving on to the outpatient and elective work. So Paul's given some of the headlines in terms of some of the capacity. Just to further that slightly, on outpatients, the trust is currently running at around the low 80s on first and follow-ups compared to the same month of the previous year. So a little more work to do to bring back the same level of capacity. But if I'm honest, I think that's reasonable about where we are at the moment. And on follow-ups, if you recall, we didn't want as an alliance and as an ICS necessarily to continue having the same number of face-to-face follow-up appointments. And I'm pleased to say that West Suffolk is doing really well, more work to do, but really well on some of its initiatives around changing the model around outpatients. So for instance, in terms of advice and guidance, so that's the work they do with primary care and other referrers around providing support which negates the need for referral they've got a higher percentage than the rest of the region and national. On virtual consultations, they're running at 30% of their overall numbers are now being seen virtually. More work to do on that, but again, relatively doing really well. And then on patient-initiated follow-up, that's the area we discussed yesterday morning at our monthly elective care catch-up, that there needs to be a little more work done. So effectively, that's how do you put more of the empower our patients actually to say when they do need to come back in for some support, rather than this regimented, I'll see you in 6 months kind of methodology. So we're looking at potentially what we can do within patient-initiated follow-up and coming back into clinics where and when they need it. And ESNEFT over in the east of the patch have been doing that for the last year. So the two hospitals are now working together to see how they can learn from one another. Just touching on the cancer work that we've got underway as well. Some really good news on that. So breast and bowel screening has fully restarted, and we're currently focusing on high-risk patients who may have missed their screening appointments. That's incredibly important as we continue to try and recover. And I'm also pleased that we've finally recruited to some of the key clinical roles as part of the rapid diagnostic service across the ICS. So you may remember that we were the vanguard across the region to test a new model around asymptomatic patients, where we're not really clear what it might be and whether it's cancer or what type. So we're rolling out a new type model where effectively those with medically unexplained symptoms can go in and get full testing, full support. And we finally recruited some key roles around that, which is great news. Just to touch finally under this part of the item on community paediatrics, as Lisa raised. Alongside the work Lisa's doing, we've also got the phase 2 of the community paediatric review underway, and we had a deep dive on this last Friday, where we looked at where the teams have got to. So Nick Hal-Smith, who's the lead for that service, is leading this piece of work with system partners, and they're focusing at the first phase on community nursing. And I'm really pleased that their ambition is to look more broadly than that at an integrated children's nursing model across primary, community and secondary care. And they'll be looking to develop a workshop in January where some of those initial ideas can be explored further across the two Suffolk-based alliances. So it is moving in the right direction, and then they'll be following on with medical and therapies. So I think at long last, we are now really starting to look at what the potential of our community paediatric services are as part of a more integrated children's physical health model in the county. I'll leave it there, Christopher. So I think that's us done in terms of West Suffolk FD and community.
Thank you very much. Does anybody have any questions at that point? Okay, it's 11:17. I think it's time. Oh yes, you do, Firaz.
Sorry, thanks, Christopher. Thanks, Paul, for the report. I just want to double check something. We're looking at this figure for 2 weeks wait and the RTT. Are we reassured that the hospital are doing what they can to work on that area?
Sorry, you go, Paul.
Yeah. So we are continually meeting with the trust and reviewing their processes. Each of the specialties have their own action plans that they are working to. We are closely monitoring essentially the capacity on a weekly basis with the trust. So essentially, yes, they do have challenges. Yes, they do recognize that they need to do more work. If you take the day case activity, for example, where we know it's not where we want to be, had a discussion with them yesterday where they're opening an additional space to try and drive further day case activity. So again, there is very close working and scrutiny into what's happening and close working. Richard, I don't know whether you want to add anything to that.
No, pretty much to endorse what you're saying. I think it's a moving feast as we get new challenges coming in. So Lisa's given the latest one about mass vax, for instance, and how is that going to, Jess waving, that's going to then impact on our recovery work. Obviously, when we need to look at what the staffing for mass vax will be versus our recovery. So I think they're doing everything they can for us, and we are as well. But it's just a moving feast to some extent. But if you look at their, as Paul said, at their 2-week wait referral numbers that are back up, and their recovery that they are making. I think despite some of the challenges, they're doing a good job.
Okay. Thank you.
Thank you very much. Any more questions on that section? Okay, it's now 11:19. Shall we break until 11:30 sharp for whatever is necessary? And we'll begin with Kate and then it'll be Jane for the final part of the Integrated Performance Report. See you soon.
11:30 sharp.
Hi, Jeff.
Hi, all right.
I'm all right. Are you?
Quickly, on the commissioning governance terms of reference,
Yeah.
if you go to the bottom couple of paragraphs, you've started to use the word chairman as opposed to chair.
Oh, right. Okay.
So if you pick that up, I won't mention it, please.
Okay. Thank you. What paragraph was that, Jeff?
It's near the bottom of the
Okie
paper.
doke. Okie doke. I've got it here. Hang about. Towards the bottom.
Yeah.
Are we still recording?
Yes.
Thank you, Jeff.
Okay.
Welcome back, everybody. We are, I remind you, on agenda item 16, part 4. I wonder if Kate is back to
Chair, it might be helpful if, while Kate's still coming back, if Lisa and I can just update on NSFT, if that's okay.
Good. Thank you.
So I don't know if Lisa wants to go first.
Yeah, sure. I mean, as Paul said at the beginning, actually the improvement on some of the access work is great within NSFT, and anecdotally we are getting less patient complaints coming through to my team. The impact of the improvements that they're doing, particularly in the CYP work, isn't being felt by our service user groups yet, but we do have a lot of confidence in the new leadership team and the work that they're doing. I think so. Flu vaccination, again, we're working with them, and they are, at the time, they're around 55% for their flu vaccination rate, which again means that they've got a significant piece of work to do. And the other thing I'll just update you on is they have had a CQC visit recently. We don't have the written feedback, the written report, but verbal feedback was that there were no concerns raised, and there was actually quite a lot of positive feedback about their inpatient and community teams. So I would agree with Paul. I think they are continuing to strengthen their processes, their services, but not out of the woods yet. Thank you.
So in terms of our transformation programme, just to concur with Lisa and Paul, I think there's a huge amount happening within the transformation space across NSFT and the wider alliance partnerships and our co-production partners. So with our community mental health model, we finally got white smoke, so to speak, from the GP Federation, NSFT and our CCG colleagues in terms of developing a more of a concrete proposal for what that community mental health could look like. And there is I think there's already been one, but there's some more sessions booked with the primary care network clinical directors, effectively getting a more of an integrated primary, community and secondary mental health model. And we'll be bringing more details of that through, I think, to a future executive. David Pennell and Ruth Bushaway will be coming with a colleague from NSFT to showcase some of that work. On the IAPT and wellbeing service, which is also doing relatively well, We've now got a business case coming through to continue to extend the access for that service up towards 30% access. At the moment, we've commissioned to a 25% access level. The national target is 30% in 2 years' time. So we'll be bringing something through probably in January once we've got that business case and we're happy and we've gone through it all. In a similar vein, we have also got cases coming through for personality disorder and eating disorders, both of which are incredibly important parts of our community mental health models. They will be looking at the pathway almost from prevention through to secondary for those two elements of our overall work. And then just on crisis, as I mentioned earlier, we've already got most of the model in place. It's now the assurance process that Paul's team's leading on, and we'll be bringing something through to the January governing body. And just to go back on children's, linked to the report that Lisa went through on the SEND outputs, I'm really pleased that we are now finally launched, as Paul said also, the neurodevelopmental pre and post diagnosis support procurement with our voluntary care sector and other partners. So I'm really looking forward to seeing what we get back from that. As you'll recall, we agreed a business case in March across the 2 Suffolk CCGs of £700,000 recurrent, really to provide much needed non-medical support for those children, their families and carers with, say, ADHD, autism, etc., etc. So hopefully we'll be able to report back good news in the new year on that. And similarly, with the investment we made of £1 million in putting further support in for children and people's crisis services, the County Council and NSFT have now reached a stage where they're going out to recruit to some of those key roles within that service. So again, in the new year, we should start to see some of the dividends of the investment that we've started to put into these services.
Chair, if I may just add a couple of things by way of assurance. Myself or one of my team members is now attending the Finance and Performance Committee at an SFT. So again, high level of scrutiny around performance is happening at that committee, enables us to have direct access to board essentially, which I think is to be welcome in terms of openness.
You're on mute, Christopher, I think.
Ed, you have a question?
Yes, I mean, there's a lot of positive updates around NSFT, whether it's from Lisa from the CQC or Richard in terms of the transformation work and the investment going in, which, you know, is great. My question, and it sort of responds to the points Lisa made about SEND, is what are the patients, the residents, the population saying about the services they're receiving? Is there an aligned view that we're seeing improvements in patient experience?
Anybody? Lisa?
So in children and families experience, then it would be no, not from Suffolk Parent Carer Network. They as they raised at the SEND revisit recently, they are not seeing the impact of the new CFIP Children, Families and Young People Leadership Team, and they still have concerns around access and the pathways, which we are fully aware that until the neurodevelopmental pathway is procured and embedded and the support has been implemented, that we're not going to see the differences in the impact on children with autism and ADHD and behaviour that challenges. So I think from a children and young people through SPCN, no, they're not seeing positive impact. My team, in the conversations that they have with the wider communities around children and young people, feel that there are less concerns raised now. And Suffolk User Forum are reporting better experiences with NSFT. But I think, if I'm honest with you, I think when next year the CQC will do the full inspection where they will go out to all stakeholders, and I think that will be quite a telling point for us around whether people's perception and whether people's experiences of care have improved.
Thank you very much. Thank you. Kate, are you now with us?
Oh. You're playing my theme tune.
Sorry. We're on item 16.4. If you've got.
No, I'm with you. I was with you all along. I was just on mute, unfortunately. Okay. Can I just add a tiny bit to what was just been said about NSFT? I think it's worth also acknowledging the support and expertise they're bringing into our quality improvement conversations from an alliance point of view. And there, James Innes there, I think his title is Quality Improvement Director, but he's the senior part of their team that's overseeing that. Having spent quite a lot of time with him in the last couple of weeks around the IHI piece that we're doing as an alliance, he's referenced several times the sort of conversations he's been having with families and children directly. And I think one of the most important pieces I took away from those conversations was how just the wealth of intelligence that they're gathering themselves firsthand, as well as working with our co-production partners, etc. I think they're also improving the way they internally receive and actively seek that kind of feedback and messaging. So that was just a little aside.
Thank you.
So in terms of the coup slide for primary care, I'm going to take the bulk of it as read. I just want to use it as an opportunity to mention a couple of other pieces, which I need to work out how I put them into this pack, because I think there's quite a lot that goes on that we miss. Having already spoken about the COVID vaccine and the amazing work being done on all sides for that, I think I'll leave that one there. We have still got a significant issue around prescribing, as detailed in the slides, and I think it's important also to mention the meds management team and the support that they've been giving to practices and will continue to. But what we also possibly need to bring back through exec is perhaps an update on the work that the care home medicine optimization team, headed up by Sarah Spinks, have been doing in terms of supporting the care homes more broadly and how they use medicines in the most optimal way to keep their patients, their residents safe and avoid admissions. That's been understandably fast-tracked during COVID, but I think what it has shown is what a valuable cog they are potentially in our kind of resilience wheel, and something that as a system we are beginning to look at exploring further, because we now have our care homes aligned to practices, and the additional support for practices I think makes a lot of sense from a medicines management point of view. We've had recently a further GP education event which have moved completely online during COVID, and that's helped it evolve in many ways, I think, and thank you to the GPs on the call who've been involved in helping mastermind that. But Rachel Seago holds the ring from our Chief Operating Officer's team, and the attendance has been brilliant. But I think the most striking thing from an alliance point of view has been the enthusiasm, I think, on both sides to name what actually primary care want to be hearing about and want to be learning about and need additional skills and intelligence on, and equally the response from the hospital clinicians to provide what's being asked of them. And I think that there's been the education sessions, but there's equally been a series of lockdown learning events which were held live on specific topics, helping clinicians on both sides understand what the situations were around their specific areas, but equally waiting lists, etc., etc. But what we've done also is taken them and put them online, so they're an accessible learning resource, not just at the hours at which the session was run. So the hits, which I think is the right way to say it, on each of these videos is building sort of week by week, and I think it's been a real success, almost acting as a bit of a library that our primary care clinicians and primary care more broadly can dip into. So I think all the teams that have been involved in evolving that as a process, I'd just like to give a bit of additional recognition to. Also the work equally led by Rachel around the join up with the medical secretaries and our practice managers and secretaries within primary care. We've started dedicated sessions working with the hospital teams on these, and I think they had one last week which was incredibly well attended. But I think the most important piece was the growing of the relationships and the growing of the understanding across the two bits of our jigsaw in terms of how each other works, which is helping with the kind of relationship and trust piece, which I think again is sort of broader than just the intelligence that's being gathered on a specialty specific footprint. And then also we've trailed and spoken previously at board around the One Clinical Community work that we've done in terms of developing our integrated neighbourhood teams, where we've had GPs, social care, community nurses and hospital consultants together, looking at their individual locality patch and developing their leadership skills as part of that. Some of you have also participated in that. We're looking at how we take that model forward in a slightly larger sense. East Suffolk mirrored our model after the last round and augmented it slightly in terms of the different disciplines that were attending, so mental health, District and Borough colleagues, voluntary sector organisations. So we're looking at whether or not, and we have a proposal on the table, that's something that we could do as a system, again, just to make sure that our integrated neighbourhood team, so that leadership model in each of the localities, is growing and being supported as we look at kind of putting more, as Richard was saying, as part of the commissioning intentions, more focus onto that neighbourhood level delivery and leadership piece. So I think that's an exciting move forward. And that was it. They were the piece I wanted to highlight, and happy to take questions.
Thank you very much. Are there any questions?
Andrew.
Yeah, Andrew.
Yeah, just getting off mute, putting my ugly mug on the screen. Just to welcome the inclusion of the box about prescribing, but to give a slight note of caution around those figures around antibiotic items and controlled drugs, in that with the onset of COVID in the April prescribing figures, there was a significant fall in antibiotic prescribing right across West Suffolk, and similarly there was a fall in controlled drugs. But of course, as we go back more to normality, we might see more prescriptions for antibiotics. But we have achieved a 20% reduction against a target of 25% reduction over a period of time in the tonnage of antibiotic items. And I think that's really welcome, and I would encourage all my colleagues to continue reducing their use of antibiotics because some of it is inappropriate. I don't think anyone suffered from the halving of the prescriptions of phenoxymethyl penicillin, penicillin V, during the spring and summer. And then finally, the prescribing leads meeting that we held last Wednesday was very well attended, with almost 60 delegates logging on to the event, and it was very helpful indeed, and I'm sure people learnt a lot. Thank you.
Thank you very much. Next, I think, is Zora.
Okay, this may not be something that you can comment on at the moment, but I was just wondering about practices and long-acting reversible contraception. So fitting coils and implants. Some practices aren't doing them. Some have been doing them throughout the pandemic. Some have stopped and then restarted. We know that ICASH are buckling under the pressure being asked of them to fit contraceptive coils for contraception. And I also know that the Suffolk Fed are now starting a service to support primary care and ICASH with coils and implants, starting in a couple of weeks, I think, in the east, rolling it out to the west at some point. Now, I haven't seen anywhere any costings for that, and I just wondered how that was being funded through the Fed, and a little bit more about how we are supporting practices to restart or the service, given the Faculty of Reproductive and Sexual Health has said this is an essential service, essentially. And we also know the Swan are continuing with their vasectomy service. Yeah, so it's just invited comments about that, really.
Thank you. I consciously placed myself on the Sexual Health Board, actually. We must have had this conversation before, Zora, as well, and with my background as well, to make sure. I think there's quite a lot of questions that I wanted to make sure we were following through, many of which you just brilliantly articulated. Fortunately, I think the most recent meeting, there was a bit of hiatus during COVID, and the most recent meeting I wasn't able to attend because of the COVID vaccination conversations, but I will catch up and perhaps take offline with you a catch up, because I know this is one of your areas of interest as well, and perhaps we can think about what we bring back in terms of the board having visibility of what the plan is. We're definitely in a better position, I think, in terms of joint ownership and visibility, but I don't have the detail to answer your question at the moment.
That's fine, thank you.
Thank you. Ed?
Yeah, just a question on the MMR vaccination achievement. So absolutely take the achievement, but what I'm not clear on is that a pleasant surprise for us in that the GPs have shown great diligence and driven the number, or did we have people snapping at their ankles to get the vaccination rates up? What was the strategy or the impetus behind it? Because it's so different to other CCGs.
I think that's a really good question, because I think that's one of the nicest things about it, that there wasn't any heel snapping necessary. It's something that I think that we've just got a widespread commitment to, and we don't have particularly good visibility of those kind of indicators at a sort of practice PCN level, and I think that's part of the conversation we've been having with the regional team, because they are now able to access that information and potentially share it. But all the information that's been shared with us today has been largely positive. So I think from a West Suffolk footprint, not to be complacent in any way, but I think we've just got a strong ethos around understanding the importance. So it's a well-deserved accolade, I think.
That's a great answer. Thank you.
Thank you very much. And finally, then, in the integrated performance report, Jane, finance.
Yes, thank you, Chair. So included in the pack is the report up to the end of October. So for everyone who was listening carefully earlier, you'll know that spans the first 6 months under the previous regime and the first month of the new regime. So it is a little bit of a complicated picture to report, but we've tried to keep it fairly simple. The first sheet shows the position as at the end of October, and the second sheet, the forecast for the end of the year. We are still waiting for the month 6 retrospective top up, which we expect to get in the next few days. You'll see in the first report that's 2.6 million that we're expecting to bring us back to a break-even position at the end of month 6. In terms of you, eagle-eyed may have spotted that we're also anticipating a top up for month 7, which sounds contra to what I explained earlier, but that's to do with the hospital discharge programme, which continues to be centrally funded. So there is a small elements of costs in the CHC programme associated with that. But overall, what we're showing in the report is a position which is in line with our first plan that we submitted. So the plan that said that we would be 3.9/4 million away from achieving financial balance by the end of the year. When we do the month 8 report, we will have revised that in line with our expectations about being closer to balance by the end of the year. The report goes on to give you a bit of a summary about the main areas of pressure, and that does obviously include those prescribing elements that we spoke about in the previous report. And the final sheet gives you a breakdown of the COVID claims by category for West Suffolk CCG in the year to date. So I won't say any more at that point, Christopher, but happy to take any questions.
Thank you. Are there any questions? Okay, everybody content, they understand where we are financially. Thank you. Right, that concludes the integrated performance report. And we will move on to governing body assurance framework, Amanda.
Thank you very much, Chair. So here we have our November risk report, where we have previously scrutinised at a recent committee. But since that date, we have continued to update and manage our risks going forward. Many of the risks covered within the report we have spoken about previously in the IPR section. However, there are a couple that we haven't. One, cyber, and we continue to progress that through the joint IT board and also the audit committees. And I'm pleased to assure the governing body that we continue to make good progress, and I think we have the necessary traction in place to manage that. We've also added from last time EU exit, and we have a paper in part 2, but just to give a couple of factoids, we have 36 days until we reach the end of December, and that concludes to 23 working days. So a lot of work is continuing to manage the risk as we move forward, but I will update further in part 2. And then I think the rest of the risks speak for themselves, but just to add a couple of other, we now have a joint approach to risk management across Suffolk and North East Essex, which is working well. And we are also about to conclude an internal audit through RSM on our own governance arrangements, including risk, which will be reported back to GB through the audit committee going forward. And we are now about to go live with Datex, which has been months in the making, but I'm pleased that training will commence on that tomorrow, which is a positive news. But happy to take any questions, Chair, but I'll leave it there for now. Thank you.
Thank you. Are there any questions? Jeff?
Thank you, Chair. I've got one of clarification, please, on the West Suffolk risk number 54, maternity. I was a bit confused with the update in the context of it was talking about provider and CCG CFOs getting together to look at the money, and then we're talking about ESNEFT putting a business case in force to their board for funding. So I was a bit confused with West Suffolk and ESNEFT and that statement. If it could be clarified, please.
Yeah, so the process that we're going through is West Suffolk and ESNEFT are both putting business cases to their boards to following their review of staffing to be able to deliver the continuity of carer model, which we've been helping as part of, we've been helping them as part of the maternity transformation team. The money is quite significant that they will be asking their boards for, and we've always kind of tried to get, well, not tried because Jane has been incredibly helpful, but try to liaise with the finance directors, because quite often the heads of midwifery get a little stuck with the financial governance processes. So I'm not sure if that comment relates to conversations that we've had between Jane and the DOF. So I don't know if Jane has any clarification.
No, I know that this is quite a complex area that we do need to try and get bottomed out before next year's budgets. But no, I'm sorry, this is not. Yeah, it's not come from me. I think we need to pick this up outside and just make sure we clarify and just get it clear.
Yeah.
Thank you. Any further questions? Okay, so I think we consider that report received and approved. Thank you. On to the governance and corporate business section, item 18, the external auditors. Jane.
Yes, thank you, Chair. So you will recall that at governing body we brought a paper putting in place a panel to look at recommendations from a tendering exercise around external audit. So pleased to say that we've been through the process. We've received the tenders. We had a what people sometimes call a beauty parade, but presentations from 3 audit firms, which huge thanks to Jeff and audit committee members for taking part in that. And the panel that we put in place basically accepted the findings on the day to recommend that we change our external auditors from our current providers, EY, Ernst Young, to BDO, who had the best combination of quality scores and price. I think it's fair to say that we were very fortunate. The audit market for public sector is very difficult at the moment, and we were fortunate that we had 3 very credible suppliers, all of which scored very well on quality, and BDO were the lowest on price.
Thank you. Are we happy to accept that?
Yeah.
Oh, we have Linda has a question.
I'm sorry, Jane, could you just explain or clarify what BDO stands for again, just
Oh golly, yes. Sorry, I can't remember what the acronym is. It's I'm sorry. I will. I'll put that up in the action log. I did look it up at the time, but it's not one that's stuck in my brain. But it is one. They are one of the top 10 audit firms that. Most of the audit firms have kind of combined over the years, and their names have come from various legacy organisations. But they are a credible player in the markets. They have a background in public sector audit. They are, in fact, ESNEF's current auditors. And apologies that I can't remember what VDO stands for. I will try and look it up before the end of the meeting.
Thank you.
Thank you very much. May we continue then to item 19, the Health, Safety and Risk Committee. Amanda.
Thank you very much, Chair. So here we have our regular update of the Health and Safety Risk Committee. As you can see, we last met on the 29th of October. We have now extended that committee to embrace North East Essex as well, which is great news. And just to pick up a couple of highlights from the report, we have concluded several weeks ago, in fact months ago, risk assessments pertaining to COVID for all of the 4 sites that we occupy, and they continue to be refreshed and uploaded onto our intranets as required. In terms of flu vaccinations for our CCG staff, as of a couple of days ago, we now have around 100 of our staff that have been vaccinated by the Occupational Health Department of ESNEFT. We have further clinics planned this week and indeed going into next week. So I'm confident that that 100 will increase a bit further. And in terms of our home working policy, we have just enhanced that to include some advice to our staff in terms of how they manage their workstations from home. So hopefully that will be well received. But I think I'll leave it there, Chair, but happy to take any questions. Thank you.
Thank you very much. No questions? Okay, thank you very much. Next, declaration of interests, item 20.
Thank you. So again, here is our regular report that comes to our governing body twice a year. This is the latest report we have as at October, and I think it's fair to say that we probably still need to further improve and enhance our internal process to get better compliance. And one recent suggestion is how we can perhaps use an electronic staff record as a way of easing that process. But that's where we are at the moment. Again, happy to take any questions. Thank you.
Questions? No, thank you. On we go. Again with you, Amanda, the terms of reference to the Commissioning Governance Committee.
Thank you very much. So here we have recently updated to reflect the way that we're currently working virtually. And for ease of reference, the changes that have been suggested are shown in red. And I think towards the end of the draft that we have in front of you, there is probably a bit of tidying up with the language with regards to how chairman is mentioned. So that's something that I do need to take away and look at. But in terms of the additions, they are shown in red. So if we're happy to approve those, I can take those forward, but also look at the clunky wording, I think, towards the end of the terms of reference.
Happy?
Everybody happy?
Yeah, thank you.
Thank you very much.
Thank you.
Minutes of meetings. Jeff, you usually lead us on this one.
Okay, thank you. Thank you, Chair. We've got quite a few before us today. So we've got the Audit Committee of the 15th of September, the Remuneration, the 6th of October, the Finance Performance of the 16th of September, COVID, there's a couple of their meetings, the Primary Care Committee and Commissioning Government's 2 committees, and the Collaborative plus the Area Prescribing Committee. So I think I would ask the board to agree those and note those minutes and ratify them. And if any of the chairs have got any comments that they want to make, then I'd invite them to do so, please. From my side, I don't think I've got anything to add to Audit Committee or the REMCON or Financial Performance. That's not already been picked up elsewhere, to be fair. And some of the decisions of the Commissioning Governance have been through before.
Thank you.
Thank you.
Any comments or questions? Thank you very much. So those are received. The next governing body is Wednesday, the 27th of January. And now in terms of the questions from the public, we do have a couple of questions, both from the same both from the same questioner. It's Councillor Margaret Marks, who, as you know, is based in Haverhill and was Mayor of St Edmundsbury a couple of years ago. And she asks, with reference to the 3 billion that Ed touched on in his report, she says, this is to support waiting lists and diagnostics, but since these delays are currently predominantly a capacity issue, and you are already using private hospitals to support this, how will this funding be used to benefit this urgent need during the COVID crisis? And I think you felt that either Richard or Paul was best placed to answer this. Ed, didn't you? So Paul's got his hand up, right? Volunteering. Paul, thank you. Yes.
I'll begin the answer, and I'm sure colleagues may want to add. So I think the nub of the question is to answer the fact that the national contract is coming to an end in December, essentially, and there is clearly a national procurement as an AQP to provide additional sort of private sector infrastructure. Essentially, this framework, the new framework, will then be picked up by the CCG, hopefully in the new year, will be then managed by the CCGs. We are currently working with our current providers at the moment to identify if there are any other area where private sector would benefit in terms of waiting lists and priorities. Essentially, we are also waiting to see what comes out of the AQP and procurement process to see what other providers may be available, as we are currently already working with our main providers in terms of private sector and maximising the capacity. So essentially, that's where we are. We're waiting for that to be completed and currently working with our providers to identify priorities.
Thank you very much. Anybody want to add anything to that?
The only thing I'd add is at the moment, obviously that's a headline message that we're expecting the Chancellor to announce later today, but I'm sure Councillor Marks would agree until we've seen the further detail of exactly what that entails, what it means, how it will work, it's difficult for us to comment at this stage. The only thing I'd add to what Paul said, though, in terms of what we're doing now is predominantly the additional capacity is coming, quite rightly, as Paul says, from the independent sector in all three parts of our ICS, but also from further extra shifts that are being put on in the evening and weekends for our existing staff, and to a smaller extent some additional outsourcing work that we are doing with West Suffolk Hospital, for instance, around cataracts, etc. But as we said earlier in the agenda, it's a moving feast and it's continuing to be a challenge. But I'm pleased that there is additional funding coming down the line, and we'll wait to see what it says when we get the detail.
Thank you. Andy, you have a question or a supplementary point?
Yeah, I just wanted to say that West Suffolk Trust have commissioned a mobile CT scanner to provide more scanning capacity, which obviously will be enormously helpful, and I think it's already helping their CT capacity. So that is an example of what can be done. Also, they are hoping to open up a third endoscopy suite, and any extra funding coming through would be helpful for that. So any similar sort of initiative.
Okay, thank you. Well, I hope that answers the question for Margaret. And then she did also put in a further question, which really was to be addressed to Barbara Gale. So I will forward it to Barbara Gale, but I think I should read it here because it has a relevance to the discussion we had at the time. And she says, please involve police in your conversation regarding death issues, as my husband died in a public place, and when I arrived, I was prohibited from seeing him in a very harsh way. It has left a lasting and unhelpful effect. I did not get to see him for 2 weeks until he arrived with the undertaker. So that's a sad story and part of the police process and coronial setup, I have no doubt, but I will forward that comment to Barbara so that she can weave it into the work that she does ongoing. That concludes the questions from members of the public, and that concludes the public part of the board meeting. We now have another link to sign in, don't we? Joe, can we start straight away or must we pause?
No, you can start straight away if you want to, yeah.
Okay. Simon, your hand is up, I notice.
I did. Just to